Good afternoon. Today we will be discussing pediatric. Okay. One thing you should know that pediatric is one of the cases that must be in the exam. So you cannot have Lab 2 without a pediatric case. You can't. Okay. And sometimes you can even have two cases. Okay. So please focus on pediatric because you will have one case in the exam. Okay. Before I start, okay, in pediatric, so we agree from the start of the branch, in pediatric, you may have a mother who is bringing her child with a condition, with a complaint. This complaint, if it's non-developmental, if it's nothing to do with his development, okay, which I call it medicine. For example, rhinorrhea, for example, fever, rash, medicine, okay? Then I will focus into the medicine part of the structure. I will show you now. However, if the condition is to do with his development, don't go too much into medicine. So if the mother is coming and she's saying to you, well, my son is having fever, then I will focus more into medicine kind of structure, because the structure will contain development as well. You're not going to go too much into development. Okay. However, if the mother is bringing her child with delayed walking, delayed talking, you're not going to go too much into head to toe, discharge, rash, because it's not a medicine station. So I will give you the structure, but I will tell you at any pediatric case, if it is medicine, what I mean by medicine, I mean fever, rash, discharge, don't go too much into development. And if it is development, don't go too much into medicine. Don't ask her, does he have any rash anywhere? She's complaining with delayed walking or delayed talking. Yeah. Okay? Does he have any? No. You can ask a question like, is he normally fit and well? That's it. You're not going to go too much into development, which I will show you now in the structure. Where is development? Where is medicine? But please, guys, because that's one of the mistakes that doctors do, that they use the structure wrong. They think that everything will be asked. Everything will be asked in the structure. No. I will give you the structure and I will tell you. In a medicine cases, I will be using this part. In the developmental cases, I will be using this part. Okay? So, pediatric structure, history taking. I will start P1, P2. So, P1, P2, bird, triple D, and math, not maftosa, only math. So P1, P2, bird, triple D, math. So what is the difference between pediatric structure and adult medicine structure? Adult medicine was P1, P2, P3, maftosa. So instead of P3, I put bird, triple D. Why? Because P3 in medicine, adult structure was diet, exercise, smoking, alcohol. The child, when you ask the mother, does he smoke? Yeah. Does he drink alcohol? That's why bear the triple D instead of what? P3. So there is no P3 in child, just P1, P2, bear the triple D and maftosa. Again, in maftosa, I took OZA. I took the O for occupation because the child will not be working. Yeah. S for social and how is it affecting his daily activity? I took this part off. So that's the structure. P1, P2, bird, triple D, math. Okay? P1, what is P1? Presenting complaint. So P1 is the presenting complaint. The mother is bringing the child with whatever. For example, vomiting. For example, doctor is vomiting. P1. After asking about the presenting complaint in details, and as I told you, presenting complaint, I will use either Socrates for pain, and I've said this in day one, or Odipara for any other symptoms, or track. What is track? For discharge. Vomiting is any kind of discharge. Rhinorrhea, nasal discharge, ear discharge, eye discharge, vomiting, diarrhea, whenever the discharge from the frontal passage from a mother, whenever from a female, whenever there's a discharge coming out of the body, I use track. Yeah, so I'm just giving you example. Okay. So the mother is bringing a child. By the way, in Black 2, there is no children. In the cubicle, there is no, you're not gonna find a child. It's always you talking to the mother or the father.
Okay.
And then you take in history from them and you're telling them management. There is no children in Plab 2 cubicle. In the room, no children, yeah? So whenever she's coming to you, hi, how can I help you? Presenting complaint, doctor, my son is vomiting. Then you will explore. Can you please tell me more about it? Or track, timing, relation, amount of this vomit, and the color of the vomit, and the nature of the vomit, and is there any blood or not? C4, color, nature, blood. After asking her, I will ask her the second question, which is anything else apart from vomiting. Anything else? For example, she told me fever. She told me what to do? Explore in details. When did the fever start? How did it happen? Did you give him anything for the fever? Did you measure it? Yes, I gave him Calpol. I gave him paracetamol. Did it help? You know? Apart from fever and vomiting, anything else until the last thing she will say? That's it, doctor, there is nothing else. Like what? That's it. So you know that there is nothing for her to say. So after that, after you ask about presenting complaint and anything else, and there is nothing else for her to say, concern. 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 You know, like the other medicine structure, yeah? Concern. What's worrying me the most? What's worrying? Always ask a concern. So the mother could be bringing the child with vomiting and fever. Dr. Mo, if I ask concern early, what will it benefit me? Imagine if she had another child. Imagine if she had a child who passed away, who died of meningitis, and he had fever and vomiting 10 years ago, for example. And today she's coming to you with her son, another son, vomiting and fever. So when you ask her what's your main concern, what would she say?
Meningitis.
Is it meningitis? Because she had terrible experience because of it. So my point is, concern is important. Then you ask her, why are you thinking it is meningitis? So always ask concern, but when you ask concern, be smart. Smart means, apart from fever and vomiting, what's your main worry? Because if you just say to her any concerns, she'll say, well, vomiting and fever. But apart from this, what's your main worry? What's your main concern? So anyway, after concern, you ask about what? DDs. What are the DDs? DDs are differentials. So after concern, you ask about differentials. Differentials. Okay. In children, the differentials, all children head to toe. What do you mean, Dr. Mo? So in pediatric, you don't need to look for DDs. In pediatric, you don't need to look
for DDs.
What do you mean by you don't need to look for DDs? Any child I will ask, head to toe. Head to toe. These are my differential at any pediatric case, head to toe. Why head to toe? Why head to toe? I will ask.
Symptoms are connected in
No, because that child cannot complain. That child cannot say, I have this or I have that, or I have this or I have that. That's why whenever I have a child, I always ask head to toe. Head to toe means head injury, yeah? Head first, head to toe. I will explain to you what is the meaning of head to toe questions at any child. Head injury, what's under the head?
Brain, meningitis.
No, before the brain, the covering of the brain, meninges. So meningitis. So I will ask about what? Any fever, any rash, any neck stiffness. I cannot say neck stiffness because the child cannot say my neck stiff. So when you move him, when you carry him, does he cry? Is he shy away from light? Do you think that he cannot look at the light? Okay, so meningitis. What is under the meninges? Brain. For example, if the child is quite old, like a child like 5-6 years old, any vomiting in the morning, does he complain of pain in his head in the morning? If you're suspecting space occupying lesion, then I finish the skull, I finish the meninges, I finish the brain. Then what is this? Eye, ears, nose. So any discharge from the ears or the eyes or the nose, any discharge, is he talking his ear for any ear infection? Okay. What is this? Mouth. Any vomiting or any difficulty in feeding? Mouth, out and in. Mouth. Any vomiting or any difficulty in feeding? Then what is this? any swollen neck or any swellings in the neck, lymph nodes, maybe infectious mononucleosis. What is this? Chest, any difficulty in breathing? Do you feel that he's grasping for air? Difficulty in breathing? Yeah? Coughing? What is this? Abdomen. Vomiting, diarrhea, constipation. Okay? Or is he bringing his legs toward his tummy, like from pain? Yeah. Okay? What is this? Urine. Yeah. So, is he crying when he's passing urine? When you take him for that? To have a wee, is he crying? Okay. In children, wee is urine, poo is stool. So is he crying when you take him to pass urine, or when you take him to the room, is he crying? Yeah. So basically, I will check all the systems. I will check all the systems. Dr. Khalid, any difficulty so far? So I will check all the systems, head to toe, head to toe. However, in any child, doctor, in any child. And when I started the lecture, I said to be careful. If the case is medicine, if the case is what?
Medicine.
I will focus on this head to toe. What do you mean by medicine, doctor? Fever, vomiting, diarrhea, constipation, discharge. Focus on head to toe. But if the case is development, delayed walking, delayed talking, I'm not gonna go into so much details. I will tell you now. So if the case is medicine, if she's bringing him with vomiting or diarrhea or discharge, I will go to head to toe in details. However, be smart. If you talk to the mother, how can I help you, doctor? My son is having vomiting. You explored the projectile vomiting. Anything else? He's having fever. You explored it. Apart from this, anything else? You found that he's got rash, he's got his neck stiffness, or he's got pain in his muscle when he's moving his neck, and you found that he's shy from light. From the start, what do you think of? Meningitis. So when you go head to toe, please, quickly. Quickly means any discharge from the ear or nose or eye, no doctor. Talking his ear, no doctor. Is he coughing by any chance, gasping for air, no doctor. What about his tummy? Any diarrhea, any constipation, no doctor. Any pain while passing urine, your history is finished. So a question each. Again, a question, because you reached your diagnosis. So question each. But do I need to go through the whole? Yes. Head to toe is a must in children. Head to toe is a must in children, because they cannot complain. However, when you know that you reached your diagnosis, go through system quickly, fast. However, another case, if the mother is bringing the child with tugging his ear. So since when? Explore. Exactly. Is it one or both ears? Explore. Any discharge from the ear? Any fever? Any problem in hearing? What did I focus on now? Ear. And after I finish my ear and I realize that it's otitis media, for example, quick head to toe. What do you mean quick? So when I go to meningitis, you don't need to ask all the questions. Fair enough, rash, neck stiffness. Fair enough, discharge from anywhere else like nose or eyes. Fair enough, you go any difficulty in breathing. Is he short of breath? What about his tummy? Any vomiting, any diarrhea? What about his wee? His wee. Is he crying when he's passing urine? His poo. Did you poo? Stool. What about his poo? Did you notice any change in his poo? And that's it. Don't go into every system. No. Okay? After finish, guys, do you know now how to code the history short? Because it's important. People, I see them taking so much history about not relevant stuff. So do you know now in this medicine part of head to toe how to deal with it? Focus on the system, focus on the problem. The system. Once you cover the system,
it's fast.
Quick. And then I will go after these, I will go to P2. Guys, are you lost so far? So P2, when I go to P2, P2 is how many questions too? Past history of presenting complaint, yeah? And past medical condition. So again, I will ask you here, if the child is coming with vomiting, so past history of presenting complaint, has he had vomiting before, prior to this episode? Has he ever had such issue? No. Past medical condition, I can ask one question. Past medical condition, not like medicine adult. I cannot say any blood pressure, any cholesterol problem, no. He has not had cholesterol yet in his life. So I can say, is he normally fit and well? Again, in the past medical condition, I need one question, which is he normally fit and well? Or I can say, does he have any condition that you take him to the GP regularly for? Which means medical condition. Any condition that you take him to the GP regularly for, or is he normally fit and well? And past history of presenting complaint, that's P2, 2 questions. P2, 2 questions. Past history of presenting complaint, if he had the problem before, and personal condition. Birth. Birth, B for birth. B for birth. I for immunization. R for red book. D for development. D for what? Development. Triple D. Triple D, 1D, 2D, 3D. Triple D, the first D is diet. The second D is dehydration. Dehydration. The third D is darb. Darb is an Arabic word. Darb is an Arabic word, so I said D, darb, which basically darb means hitting or beaten up, so it's NAI. So I have to execute NAI in all cases. All children, I have to look generally, because can the child complain and ring and say I'm getting abused? No, but you only know when he comes to you for something else. When the child comes with bronchiolitis, you find the bruises. You suspect NAI, for example. So NAI in children, it's your job to find out. It's not, nobody will bring, oh, I'm abusing my child. So that's why every single child, NAI, non-accidental injury, you must think of it. Anyway, Maftosa, MAF, M for medications, A for allergy, F for family history. Okay, now come to birth, triple D, B for birth. Simple question. How was his birth? How was
his birth?
Was he full term or premature? Is that relevant?
Yeah.
Of course. Premature children have plenty of issues. So what is the question in birth? How was his birth? Was he full term or full term? Was he full term or premature? How was his birth? Was he full term or premature? Okay, was it normal delivery? Did you have any issues during delivery? That's all questions. Immunization, which is jabs. Is he up to date with his jabs? Is he up to date with his jabs? Red book. Red book is a book that basically whenever he goes to the GP, whenever he goes to the doctor, they record what happened and the management. Like we had back home a while ago in Egypt, the NHS book. When we're children at school, we go, whenever we go to the GP, he write down condition, management. So it's called a book. So red book. So red book means any issues that doctors have or any condition that he went to the GP for, they have this book. So you ask her, does your child has a red book? She will tell you yes. Usually for all kids, young kids, they have red book. Any concerns? Any concerns means in the red book. Okay. Because any concerns from the doctor will be written there. So, does he have a red book? Yes. Is there any concern from the doctor? No. Development. Development is basically the way the child is developing. We have in Black 2 a case of delayed talking, a case of delayed walking, and a case of autism. Delayed talking, delayed walking, and autism. 3 cases regarding development. So in this, you ask one question. How is his development? How is his development? How is what?
His development.
How is what? His development. How is his development? Is he developing well? Yes, doctor. It will be a random. What I mean by it will be one question if the station is not development. Okay. If the station is nothing to do with development, you will ask, what do you mean one question? How is his development? Any concerns? No. That's it. But you don't need to go through development questions in details unless the case is and I will tell you now what are the questions in development.
Okay.
So again, if the case is medicine, fever, vomiting, do you need to go through the development questions in details?
No, just one
No,
question.
just one question. How is the development? That's it. However, if the case is development, I will go through the development questions in details, and only head to toe 5 seconds. Is he fit and well? Is he active and playful? By any chance, any fever, any rash anywhere, any discharge anywhere, any vomiting, any constipation? That's it. Do you understand? Really? Or
Yeah.
so if the case is medicine, head to toe in details, and not only in details of the system, and the rest quick. If the case is development in details, and head to toe quick. Okay? So, for example, if she's bringing him, okay, let me 20. Okay, for example, if she's bringing him with a, I'm just gonna give you the developmental questions. Questions in development. For example, if she's bringing him with something in his development, for example, delayed walking, delayed talking, what are the questions? In development, you'll ask her, how's his development? Is he developing well? Yes, doctor. But does she know really about development? No. Then you will ask her these few questions. This is the child. This is his head. This is his neck. This is his body. This is his buttocks. This is his legs. Yeah? Head, neck, buttocks, legs. Clear?
Okay.
Head, neck, buttocks, legs. So I will ask her about his development. How? Number one, what is the first thing that comes? Here. Here, head and neck. Head and neck. So 3 months, he's able to support his neck. 3 months, he's able to support his neck. So take the head off, starting from the neck. So neck, what comes after the neck? Buttocks, what's after the buttocks?
Legs.
Legs. So neck, buttocks, legs. Neck, 3 months.
Okay.
So neck, 3 months. So he's able to support his neck at 3 months. Then go down to the buttocks, 6 months. So 3, 6. Okay? Buttocks. And then what is this? Legs. Walking. He started walking at 1 year. He should be starting to walk but with support. He start walking with support or standing. He can stand at 1 year. What about 2 years? 2 years up and down the stairs. 2 years what?
Up and down the stairs.
3 years. 3 is number 3. 3 is number 3. 3 means tricycle. He can ride a bike. So tricycle. He can ride a bike. So again, I'm talking about development, yeah?
Yeah.
Only I will ask these questions if the cases.
Development.
Can you ask sitting or neck or standing if the case is meningitis?
No, of course
So,
not. Okay.
please focus on this because people mix it up. People ask everything and everything. No. So, if the case is development, which will come later, I spend the time on the structure, but things gets easier. If the case is development, I said to you, this is the child. Neck, buttocks, and legs. Neck,
3 months.
support his neck 3 months. Buttocks, 6 months, and you can even call it 6 to 9 months.
Okay.
So 6 to 9 months is the buttocks. 6 to 9 months. 6 he can sit with support. 9 he can sit without support. That's why I said buttocks is 6 to 9 months. So buttocks is 6 to 9 months. Why, Dr. Mo, 6 to 9 months? 6 sitting,
With support.
9 sitting.
Without support.
Then go to the legs. The legs 1, 2, 3. The legs what?
1, 2, 3.
1 he can walk, support or stand. 2 stairs. 3 tricycle. That's it. So these are questions for the gross development of the child. Gross development. It's very tough to memorize these things. That's why we try to make it
Easy.
simple. But this is what's written in the books. In our pediatric books, yes, that's the age. So that's when you ask about walking and support or not. That's gross development. What about the fine motor development? This is one of them is gross or motor, the other one is fine. Yeah, these are the gross, the fine. The fine, they told you that child at 2 years old, he can unbutton the large button. At what?
2 years.
2 years old. By the way, this is called gross motor.
Okay.
As you know, gross, big things, neck, walking. So I'm talking now about that.
Fine.
The fine. Fine, so at 2 years old, look. At what? How many fingers is that? 2. He can open that large button. At 2, he can open large button. At 3 years old, he can grasp a marker with his thumb and index. That's at what age? 3. So 2.
2 fingers.
2 finger button.
Okay.
3.
You can.
No. 3. 2, 3. Okay? And he can even dress himself at 3. So at 3 years old, he can even dress himself at 3 years old. Okay? So he can dress himself. What about 4 years old? 4 years old, he can draw someone he can recognize. He can start drawing. I'm gonna draw my dad. I'm gonna draw my mom. Yeah? So he can draw recognizable person at 4. At 5 years old, he can write, he can print his own name. Okay? He can cut with scissors. So anyway, this is only when the case is development. Guys, are you lost?
No.
Can I ask a patient, a mother who's bringing the child with something medicine, development?
Of course not.
No. If the case is development, development. If the case is medicine, medicine. But if the case is medicine, medicine, but one question, development. How is his development? If the case is development, development, in details, and medicine, one question. Clear?
Yeah.
Now, diet, delay, the diet and dehydration and the NAI, which is DARB. Diet, how to ask about diet? Simply, asking about diet is what do you give him or what do you feed him? So asking about diet simply, what do you feed him? Any change in his diet? Is he breastfeeding or not? If he's like a year old, 9 months, 8 months, do you breastfeed him or not? Is he gaining weight? Very important. So diet, what do you feed him? Any change in his diet? Because if she's bringing him with vomiting, it's very common. For change that. So what do you feed him? Any change? That's the diet questions. What do you feed him? Any change in his diet? Is he breastfeeding or not? Is he gaining weight? Okay. And by the way, diet in all cases, you must ask that. Triple D in everyone. Triple D in. So the only thing is head to toe and development. Whichever case, medicine this, development this, but the rest is everywhere.
Okay.
Because diet can cause everything, can cause developmental problem, can cause medicine problem, yeah? So these are the questions for diet. Dehydration, what are the questions for dehydration? Dehydration can be mild, it can be severe. Yeah? So what are the questions for mild? Dry mouth. Is he crying without tears? Is he not wetting his panties, or is she or he not wetting the nappies as often? But what about that severe dehydration? Drowsy, not himself, sleeps a lot. Drowsy, not himself, sleeps a lot. Severe. Mild, cry without tears, dry mouth,
Does not wet his
and does
nappies.
not wet his nappies. That's for dehydration.
Okay.
Should I ask dehydration in all cases? All cases. All cases, all cases. Clear.
Yeah.
So in all cases, I will ask triple D. What about NAI? DARB. NAI, again, if the case is not, please guys focus on these things. If the case is not NAI, if the case is like meningitis kind of case, bronchiolitis kind of case, I said you must ask triple D.
Okay.
But the NAI, you will ask one question. If the case is not, so if the case is not NAI, if the case is not NAI, it's meningitis, bronchiolitis, I will ask one question in NAI. What is the question? How's things at home? Things good, doctor. Or do you have a social worker involved? Doctor, no, it's gonna be offensive. No. I am a father, I've been living in UK for 13 years. I get asked this question normally. Do you have what? social worker involved, which means if there is social worker involved, it's NAI. There is, or not, it's not, there is NAI involved, because we only involve the social worker if there is abuse. So one question you ask, do you have a social worker involved, or is everything okay at home? That's if the case is not NAI. What if the case is NAI? Dr. Mo, how do we know? Don't worry. In Plap 2, you will know the case at the door. It will tell you a child with spiral fracture. So you know you are approaching NAI case. So at this, would you ask one question or would you go into details? Details which are, so NAI. If the station is not NAI, how many questions? One. Which is, is the social worker involved or how's things at home? But if the case is NAI, I will write it down here. If the case is NAI, what are the questions I will ask? Environment. Environment, yes, environment. What do you mean, Dr. Mo, environment? Environment means who does the child live with? Who does he live with? Doctor, he lives with me and my boyfriend. So how many people now?
2.
So me, look, me and who?
Boyfriend.
My boyfriend. So can I suspect the mother to be abusing? Yeah, of course. Can I suspect the boyfriend?
Yes.
So can you see, me and my boyfriend, that's why I said environment. Whenever there is an abuse case, you must ask environment. So who does this person who's getting abused live with? Because you're suspecting anybody can be abusing. So me and my boyfriend. So you ask her some questions and boyfriend some questions. So you ask her, you say to her, okay, how's the relationship between you and him? Do you get on? Then you ask questions about stressors in her life, because she can beat him up if she's stressed. So what do you do for living? Are you managing financially? Okay? Do you take, I'm sorry to ask these intrusive questions. Do you take any alcohols, any recreational drugs? So all these questions been asked to who?
To the mom.
Mom. What about the boyfriend? Same questions. How's the boyfriend? How's the relationship between Adam and the boyfriend? Okay? Is he the biological father? Because maybe it's not his father. Okay? Again, same questions. Stressors. Is he drinking? Takes drugs? And what does he do for living? Is he managing financially? What if me and my boyfriend and my sister?
Ask about her sister too.
The 3 of them, same questions. So my point is, whenever there's an NAI case, would I ask these details or not? Yes. What if it's not NAI case?
Don't ask.
No. How many questions? 1. So triple D is a must in every structure. Guys, you must understand the structure. And you must have it in your head, embedded. And you just think of what you ask and what not. MAF is any medications, any allergy and family history of any condition from her side or her and her partner, from you and your partner. Any history of any condition that runs in the family on both sides. Guys, any problem with the structure? By the way, every single case, 5 minutes. If you understand this.
Okay.
Why? If the case is NAI, which part I will start my structure with? NAI questions, environment. If the case is development, which part I will start my question with? Development. We'll go up there. If the case is medicine. So my point is, focus carefully. If it's written in the question, a child was brought by his mom because he had his arm twisted, spiral fracture. His arm what? Twisted. So what is the presenting complaint? Twisting of the arm. So what is P1? Twisting of the arm. So I will ask, how did it happen? When did it happen? The time of presentation, which means how long since it happened and now, okay? Because delayed presentation, if she brought him 5 days after the problem, it's a in the eye, yeah? After executing the presenting complaint, what comes after? In the eye questions, because it's twisting the arm is abuse, then I will bring in the eye there as differential, as my DDs, as, yeah? Okay, what if the case is development, delayed walking? So what is the presenting complaint? So what is my P1? Delayed walking. Since when? How did it happen? And when you say delayed walking, do you mean that he started walking, then he He stopped or he has not walked yet. What about his crawling? He started, was he crawling, I mean, at the time when he was supposed to be? Yes, doctor. As P1, what about my DDs? My DDs is the developmental question. Guys, you understand? So DDs will be NAI questions if the case is NAI. DDs will be developmental question if the case is development. DDs will be head to toe if the case is medicine. I hope you got it.
Yeah.
And that's it. Plus explore the problem. So what about triple D? Everywhere. So I will take this because if you understand the structure well, okay, you will get everything well. Okay, and I will take this head to toe. Okay. So how can I help you? P1, doctor, fever. Doctor what? Fever. So I will explore fever and I will ask about any other symptoms. Any other symptoms? That's my P1. What about the DDs? Head to toe or development or NAI? So, and the head to toe question. Head to toe questions. Then normal structure till the end. How many questions development? How many questions NAI? One. One NAI development. Okay. The second example. How can I help you? Doctor, my son is not walking. So what is my P1? Not walking. I will explore. Then when I go to DDs, DDs will be head to toe or development or NAI? Development. So my DDs will be development. What do you mean, doctor? Your DDs will be developmental questions. He's not walking. So neck, at what time was supporting the neck? What time supporting the buttocks? What time was he walking? Up and down, this, that. Okay? The developmental problem. Fine. Button. You know? What about if the case is NAI? Doctor, twisted arm. So what is my P1? Twisted arm. Explore. After exploring it, what's going to happen? Should I talk about development or head to toe or NAI? NAI. So I'll bring NAI as DDs. So NAI will come here. Will come here as environment. Environmental questions. After asking about the environmental questions, who's there, who's at home, 4 people at home. So every one of them, how does he get on with him or her? Any stressors, job, finances, alcohol, drugs. Second one, same. How do they get on? Stressors. And I will focus in the biological father. Who's the biological father? Clear, guys? And the triple D's everywhere. And bird as a quick question everywhere. Okay. So just you knowing which part I'll bring first. You knowing if the case is delayed walking, should I ask head to toe in details or not? If the case is developmental delay, should I ask NAI in details or not? No. So one thing you will focus on. Development. NAI. Medicine. Head to toe. Okay? So let's leave the structure here and start discussing the stations one by one. Okay? Quickly, so we can. The first case is pyloric stenosis. Pyloric stenosis. So you are an FY2 doctor in the pediatric department. 6 weeks old Adam was brought by his mom because of persistent vomiting. Persistent? So, will you have mother inside or mother and child? Mother only. How can I help you? Doctor, my son is vomiting. I'm really sorry about that. Can you tell me more about it? She will tell you whatever. Then, what is the word that I will use to explore vomiting? Track. Timing. Relation. Is it related to something specific? Amount, color. She will tell you the timing. She will tell you that's right after birth when I started feeding him. She will tell you it's what? Projectile vomiting. And she will tell you anything I give him, he vomits. Okay. Apart from vomiting, anything else? No. So only, that's it. Again, only vomit. So it will be only vomiting, it will be 6 weeks old, will be a boy, and it will be her first boy, her first child. Clear?
Yeah.
Okay, because it's vomiting and it's explored. Your differential, head to toe or development or any eye?
Head to toe.
Head to toe. I will exclude everything. Is meningitis can be excluded? Yes, because meningitis. So head to toe quickly. Head injury can it cause vomiting? Head injury, definitely. So head injury, go to them. As I told you, the head to toe. Head injury, meningitis, rash, fever, shower from light, specific lung lesion. Is it in the morning? Okay, then any discharge, nose, ear, eye, then any swelling in the neck, then is he gasping for air, then apart from vomiting, any direct constipation, then when he's weeing, does he cry? That's it. Everything is negative. Only vomiting. After that, I will go past the history, present complaint, past medical condition. Past condition, which means what is the question for past medical condition that I said. So apart from this, if you have any problem, any other issues, no. Go to birth quickly. How was his birth? Full term or premature? Up to date with jabs. Read book. Development. One question or too many questions? One. Diet. Very important or not? I said to you triple D everywhere. What do you give him? And do you feel that he's gaining weight? Second D is dehydration. Is it important?
Yeah.
Of course, vomiting. Vomiting. So in detail, the questions about dehydration, crowd out, tears, dry mouth, everything. Then in the eye, just you don't even need to ask 6 weeks, so you can say, well, was he planned pregnancy? Yes, that's it. So that means plan means wanted child. Then is there any medications at all, any allergy or any family history of any condition in both husband and wife? That's it. Positive finding, only vomiting. Now, what will be the explanation? The explanation, Paediatrics stenosis. It is a, first of all, verbalized examination. Observation and abdomen, yeah? Then explain to her, you will have in this station, pen and paper. So draw for her the stomach and the outlet of the stomach blockage. So from the information you're giving me, what will happen, tell her, usually our tummy opens into the bowel, the small bowel. This opening between the tummy and the small bowel, sometimes it's blocked, which in Adam's case, it is blocked, so the food does not pass through the small bowel. It runs in the family. Usually it comes if the child is the first boy, and it comes to boys, not girls, and basically when he's 6 weeks old, that's when we know. That's it. Management. Your job as an FY2 doctor, your job as an anyway, the case, management, only surgery. But your job as an FY2 doctor is what?
Dehydration.
Correct dehydration. That's it. So admit, yes. Senior, yes. Investigations, what? All blood, mainly ABG. Mainly?
ABG.
Because of dehydration. So all blood, mainly ABG. Okay? On the tummy, what are we gonna do? Ultrasound. Ultrasound scan, gel scan on his tummy. So all blood, mainly ABG. Because it will show metabolic alkalosis. Ultrasound, gel scan to confirm it. Step 3 is symptomatic treatment. No, step 4. So admit, senior, investigation, symptomatic. Symptomatic treatment, what would you give? Fluids through the veins, through his veins. And then specialist what? Pediatric surgeon who will do surgery to cut or to do a small cut in this snarling. Okay, so to open the stomach into the bowel. Okay, and that's it. First case. Second case, intussusception. Again, intussusception. What is the difference between intussusception and Paediatrics stenosis? What is the only positive finding in Paediatrics stenosis? Vomiting. Intussusception. The only positive findings in intussusception, it will be vomiting, diarrhea, in brackets, red currant jelly stool. Red currant jelly stool, in brackets. What is the color and everything? Red currant jelly stool. And pain. So what are the 3 symptoms? Vomiting. Because basically, the bowel is telescoping. The bowel is telescoping like this, so blocked. So vomiting from there. Doctor, where is the diarrhea coming from? because of this necrosis or this telescoping the secretions, that's why it's mixed with blood and things. So red current jelly, stool, and what else? He's in pain. Okay, that's it. How can I help you? Doctor, my son is vomiting. So in this case, they can even bring it as a child coming with inconsolable cry. What's inconsolable cry? Inconsolable cry, he's crying all the time. I cannot calm him down. Again, same. So you are an F1 doctor in A&E, 20-month old. Is he 6 weeks? 20 months, that's the age when it's common. 20-month old, crying, inconsolable cry, or vomiting, or having strange stool, any of them.
Okay.
How can I help you? Presenting complaint, vomiting, or inconsolable cry. What to do with the complaint? Explore. Vomiting, track, in details. Anything else? Doctor, inconsolable cry. Explore the cry, since when, how, you know. Anything else? Well, no, doctor. If she said no, she said no. Then I will go into differentials. What are my differential?
Head to toe.
And in the head to toe, I will come to stool. You understand me?
Yeah.
That's if she did not say that he's having diarrhea that's changing color and the stool, if she did not say, but she might say early. But if she did not say, would you miss it? No, because you will go head to toe, and then the head to toe, abdomen, vomiting, diarrhea. You say to her, how is his poo? She will tell you, doctor, it's like, you know, red in color and, you know, so red current jelly stool. These are the only 3 findings in this case. Any problem? Then I will go quickly. Has he, a doctor, has he had this before? Any, because he's 20 months, so you'll say to her, does he have any healthy issue or any condition that he goes to the GP regularly for? No. Birth, quickly, 1 question each. What about the development? Would you like to go in details? No, 1 question. Then triple D. Diet, dehydration, NAI. Diet is important? Yeah. Definitely. Dehydration? Definitely, because of the vomiting. NAI, 1 question or plenty? 1 question each. That's it. Move on. Then what are the positive findings? I told you. Yeah? Red current jelly stool, vomiting, and pain. That's it. Then I will go to the provisional diagnosis. I will say to her, basically, it is a condition of hystomy where there is telescoping. The bowel is like a tube, and there is telescoping of his bowel that led to blockage of it. So telescoping that causes blockage or obstruction, as I explained to you. Okay, our bowel is like a tube. In this condition, what he had is telescoping of his bowel that led to obstruction. That's it. That's the provisional diagnosis. Examination comes before provisional. So history, examination, provisional. In examination, I would like to examine him. I'll check the observation and history. Okay. Now, management. Management. How to manage? Admit. Definitely. Admission. Step 2 senior. Definitely senior. Step 3 investigation. What are the investigation? Again. All blood EBG. Again. All blood EBG. Again. Jelly scan. So same. Again. Jelly scan. So all blood EBG. Again jelly scan. And there is, when you do the jelly scan ultrasound, there is donut or target sign. Okay. Donut from lab 1. Donut sign or target sign because of this. Okay. And with the paediatric stenosis, olive like mass, they feel paediatric stenosis. Yeah, here is donut sign or target sign. Anyway, but 1 extra investigation I will add here. 1 extra investigation I will add in this case is intussusception. Erect X-ray, stool culture, perfect. Erect X-ray. Why erect X-ray? Why we need an X-ray in an erect position? To exclude intestinal obstruction, because he's similar, pain, vomiting. Yeah, the other one, no, there is no pain, there is no, you know. So, erect X-ray. Okay, step 4, symptomatic treatment. What would you give?
IV fluids.
Same, IV fluids, flow through his veins, and that's it. What about the management? And painkiller, perfect. What about the management? In this case, I have 2 steps of management. Number 1, they could start with simple procedure, which is under radiology specialist, on which they try to push the bowel using air and water, enema, double contrast, again. So I have how many ways of management? 2. specialists. After giving the fluid, I can talk about the specialist. Number one is because there is telescoping, they can as if to open it. What is this? It's double contrast enema under radiology specialist, and this procedure is a simple procedure to open the obstruction. What if it's failed? Second step, surgery. So if it's failed, if the enema failed, the double contrast enema, then we'll go for surgery. Okay? That's it. So, second case. She will ask you some questions. Doctor, can it happen again? Yes, 5 to 15%. It can happen, you know. So, any problem? Third station, bronchiolitis. Bronchiolitis. How can I help you? Again, you are an FY2 doctor in the pediatric department. 9-month-old child brought by his mom with poor feeding, inconsolable cry, fever, and he's short of breath. He's not breathing properly. These are the symptoms, and these are the words in the question, and this is the presentation. The case is bronchiolitis. Bronchiolitis is specific at 9-month-old. 9-month-old children, bronchiolitis. Okay. So how can I help you? She will give me the presentation of he's not breathing properly. He's not what? Breathing. Or she can give me the presentation of fever, or she can give me inconsolable cry, whatever presentation. What to do? Explore. After you explore anything else, she will tell you the rest of the symptoms. The rest of the symptoms. She will tell you doctor is not breathing properly. Not breathing properly? Yes. So what is the problem now? Now we talk about chest. So ask about any cough. When you say he's not breathing properly, since when, how did it start? Exploring details, and ask about the cough, and then go back to your differential. Differential, is it head to toe or is it not head to toe? Head to toe. So head to toe quickly, okay, because he's got fever. Can it be meningitis? It can. Can it be whatever? So ask about head injury, ask about rash, shower from light, discharge from ear, nose, mouth, ear, nose, eye, sorry. Ask about vomiting, or diet. Go to the neck, any neck swelling. I already asked about just early because that's what she came with. Yeah. Then go to the abdomen, any vomiting, any diarrhea, any constipation. Then go to the urine, pain while passing urine, in details. After that, P2, again, has it happened before medical condition? After that, birth, one question each. Development, one question each, or full. One question. Okay. Then diet, dehydration, and NAI. Diet in details. Why in details? It's in details in every single case. I said to you, triple D is everywhere. Everywhere. Okay, and especially that the question said poor feeding. What about the second D? Dehydration. In details. Why? Because this child will be dehydrated, yeah? Bronchiolitis will be dehydrated because he can't breathe. And because he can't breathe, he can't feed, which will lead to dehydration. So dehydration is a must here, because the child will be dehydrated. Then in the eye, one question, and that's it. Now, what is bronchiolitis? By the way, when you ask her about MAF, family history, she will tell you his father has asthma as a positive risk factor. His father has asthma. Examine, verbalize examination, vital and chest. Then provisional diagnosis. How to tell her provisional diagnosis? A condition called bronchiolitis, which is infection in his lungs. Okay, guys, let me tell you something very important. Bronchiolitis, is it viral or bacterial? Viral. It is caused by respiratory syncytial virus. We don't need the name of the virus, but I'm just telling you. Okay. It is viral infection. It is self-limited. However, we are treating what?
Virus. The symptom.
The symptoms, which is shortness of breath, oxygen is low, saturation, oxygen he will need, dehydration, so fluids he will need. Am I clear? Yeah. So you will tell her it is an infection in the lung, but it is viral infection that goes on its own. However, we will manage the symptoms. Doctor, would you give him antibiotics? No. No. So management, admit, senior, investigations. This is the third case in a row. What is the most important investigation? ABG, because of dehydration. All full blood count, infection, but ABG as well. Okay, and chest X-ray. And he will have this child. We will get nasopharyngeal aspiration, sample of the discharge, because she might say to you nasal discharge. So one of the presenting complaint as well could be
nasal discharge.
So I will take swab. Step 4, symptomatic treatment. So don't forget in the investigations. All blood, mainly ABG. Chest X-ray and
Swab.
nasal swab, nasopharyngeal aspiration. Now, step 4, symptomatic treatment. What are the symptomatic treatment? IV fluids, because he is dehydrated, and oxygen. So IV fluid because dehydration, oxygen, and you can give him even nebulizer with salbutamol. Okay. Okay. Station number 4.
So management, admission or no admission?
Admission, because the child will be. He's gonna come presentation dehydration. Yeah. Next station.
Pediatric chest consultant.
No. Just admission, because you don't need pediatric chest consultant, because it's a case of viral infection and it will be admission in the hospital. Which chest, which department? It's a pediatric hospital. So it's a pediatric hospital. So no. Next case, you are an F1 doctor, 10-month-old Ryan has been sick for 2 days and his mother is calling. Okay, that's a phone call station. Anyway, in a phone consultation, we know the approach. However, it will be explained in a special video how to approach over the phone. So over the phone, you will confirm her name, you will confirm her son's name, her son's date of birth. Then I'm the doctor here, how can I help you? Then she will tell you, doctor, my son had fever. This case is exactly the same case as the bronchiolitis, but it's not bronchiolitis, it's just a case of dehydration. So this case is a case of, that's it, phone consultation, dehydration. So how can I help you? She will tell you, doctor, my son is feverish, he's got temperature. Explore, since when, how did it start, everything about temperature. Then, would you ask head to toe or not?
Yes.
Head to toe. In this case, you will ask for all head to toe. Everything, it's a case of dehydration. Everything, and be careful, because in the provisional diagnosis, when you reach after taking history, the main focus will be he's dehydrated. The child is having fever. And the child, because of the fever, it's causing dehydration. This fever could be any cause. Could be viral infection, throat, could be, for example, ear, could be nose, could be, but be careful, because in this case the child will be dehydrated, in dehydration. So management, the child will need to be admitted, senior, investigation, all the blood, ABG, and IV fluid. So this is a case of dehydration, pure dehydration case, okay? Next,
Bring the child over.
Definitely, you will sit her right away. We'll send the ambulance. They can bring the child and they can be managed in the hospital. Yes. Okay, because it's dehydration, he cannot be managed at home. Okay, but you need to look for the source of. Don't forget. What is the presenting complaint? Fever. So if there's a fever, that means there is infection. Okay, this is a case of whatever the source of infection, you will know by asking system-wise. Is it chest? Is it gut? Is it where? But make sure that there is dehydration in this case, which you need to admit and manage. Okay. Next case. Okay, next case is a case of febrile convulsion. Febrile convulsion. Before I start this case, febrile convulsion, what is the name of it? Febrile what?
Convulsion.
So that means it's a fit due to
Fever.
fever. Okay. Why do you say this introduction? To tell you that at any case, if the child is coming, is brought by his mom, and he's having fit, and you take history and there is fever, so is it reassurance or not?
Yes.
Reassurance. However, what is the cause of the fit? Fever. So you need to look for the source of infection. So it's a case, this case is a case of a child who was presented, his mom brought him because she said he's having a fit. I just like to give an introduction so you understand the case before we start.
Okay.
His mom said he's having. When you explore the fit, it did not last long. When you explore the fit, it did not happen before. Then when you say to her anything else, he's having fever. Explore the fever. Anything else, he's stuck in his ear. So what is that? So he's having ear infection that's causing him to have fever, that's causing him to have fit. So now in this case, when you take history from here, there's no discharge, there's nothing, it's ear infection 2 days. Okay, the ear infection 2 days, do you give antibiotic? No, you don't give antibiotic. Unless it's unilateral with discharge or unless it's not managed for more than 5 days. So you don't give antibiotic, it's viral. It will go on its own or not?
Yes.
What about the fit? Reassurance, because it's febrile convulsion. So how many cases you have here? It's like you have 2 things. You have the fit and you have the, for the fit, what to do? Reassure, but advise her about the recovery position.
Okay.
Again, for the fit you reassure, but you advise her about?
Recovery position.
Put him on his side, nothing next to him, don't give him any tablets, don't give him anything in his mouth. And for the ear infection, viral supportive treatment. Did you understand the case?
Yes.
So now, how can I help you? This is the case of Mrs. Andrew brought her 20-month-old Alex with a complaint of fit that lasted few minutes. Okay, let's focus. How can I help you? Doctor, my son had fit. So what to do? Explore the fit. And when we explore the fit, we have a way of before, during, after. So during the fit itself, when did it happen? For how long did it last? Did he lose consciousness? So again, during the fit, what are the questions? When did that happen? And for how long did the fit last? Did he lose consciousness? Or did he bite his tongue? Did he hit himself? That's during the fit. Before the fit, what was he doing? What was to see what initiated the fit?
Okay.
Before the fit, did he eat properly? Did he have his meal as usual? Because it could be hypoglycemic fit. Now, after the fit, did he injure his head? Yeah, did he have any head injury anywhere? So that's after the fit, okay? So basically, you will explore the fit because it is the presenting complaint. Before, during, after. After exploring the fit, anything else, she will tell you he's got fever. Explore the fever. Anything else, he's talking his ear. Explore. And now you know that presentation. Fit, fever, talking ear. That are you lost. Now when you go to DBs, head to toe or not?
Head to toe.
In details, all of them, to exclude meningitis, exclude everything, you will only find that it's ear problem and the fit. P2, Barrett. Question each or full question each. And then triple D. All of it or not? All of it. Diet, dehydration, and NAI. One question or many questions in NAI? One question. So after that, I established that it's a fit and there's ear infection there for the past 2 days. So, examination, verbalize. I will examine his ear and observation. Provisional diagnosis, this fit is due to the fact that he's having fever, which we call a febrile convulsion. Then, move on to management. Admission? No. Maybe put him under observation, yes. But admission, no. Senior? Yes. Investigations. What are the investigations? All the investigations. Blood, all the blood, infection marker, yeah. Step 3, symptomatic treatment. What for?
For the infection.
Otitis media. Ear infection, so Calpol, which is paracetamol, plenty of fluids, supportive plenty of fluids, paracetamol, lightly dressed, don't overdress him because of the fever. That's for the otitis media. However, regarding the fat, you were worried about the fat. I can assure you that it's called febrile convulsion, and he only had it because he had fever. However, I would like to advise you that to prevent this fit from happening, how to prevent it from happening is make sure whenever he gets a high temperature to give him paracetamol. Why? What's the cause in it?
Fever.
So whenever he's having high temperature, to give him paracetamol, to give him calpol, light dressed, don't overdress him, to give him plenty of fluid. I'm advising here. So to prevent the fit, it's happening because of fever. But if he has the fit, what to do?
Recovery position.
Lie him on his side, with his face turned on the side. Don't put anything in his mouth. No medications. Sit and watch. Sit and watch. If it's less than 5 minutes, do nothing. If it's more than 5 minutes, ambulance. Ambulance. Then she'll ask you, doctor, is it epilepsy? It's very rare. Can it lead to epilepsy? No, it's rare to lead to epilepsy. Okay? Now, if they live 2 hours away, you can give them some medication, suppository for the child. If they live 2 hours away from the hospital, okay? So if they live 2 hours away, you can give them medication. It's called rectal diazepam. Okay? Now, rectal diazepam to prevent that, or when he has the fat, you have to stop the fat, yeah? Now, I can bring you the case, another scenario. Listen carefully. Okay. Another scenario. And you tell me what is the difference. Mrs. Andrew brought her child to the A&E because of the fat. She's concerned about fat. On examination, that it was found that the eardrum is congested. The eardrum is congested and red and swollen. Talk to her, address her concern. So what does that tell you? It is making your job easy. It is only fat. And they're telling you, by the way, we examined him and there is ear infection. So saving your time exploring the ear infection. So it's basically telling you febrile convulsion. Do you understand it? Yeah. So the first station, the first scenario, blind. This child has fat. When you talk to her, you find that he's got ear problem. But this scenario, they're telling you in the question that on examination of the eardrum was red and swollen. Okay, so you can say to her, from my notes, I can see that we've examined his ear and it's red and swollen, which means that he's got some infection in his ear, which is viral infection. So you can use it to give it to her. This note, okay? By the way, what are the causes of fat? If you have a general case of fat, a child coming with fat, what can cause a fat? Meningitis, number 1. Space occupying lesion, number 2. Epilepsy, number 3. Head injury, number 4. Hypoglycemia, number 5. Think about it. A child with meningitis. A child with fat. Child with? Could it be? Head injury? Could it be meningitis? Could it be space occupying lesion? So, from outside to inside. Head injury, meningitis, space occupying lesion. Plus 2 other conditions, epilepsy and hypoglycemia. Am I going too fast?
No, it's okay.
No. Okay. This case, the next case, is a case that is telling you, is a case to check. Do you know the indication for CT scan in head injury or not? Okay. Again, this case common is to check because every case has a purpose. Every case has a purpose. The purpose of this case I'm gonna tell you now is, do you know the indication of a CT scan or not? That's it. So this case is, you are an FY2 doctor in the pediatric department, 9-month-old was brought by his mom because he had a fall from the sofa. He had what? Fall from the sofa. Okay. Before we talk about the case, what are the indications of a CT scan head injury? So if a child had head injury, yeah, when do we do CT scan? What are the things that if I get to know, I will do CT scan? Indication. When do CT scan? Number one, if there is loss of consciousness more than 5 minutes, write it down. Loss of consciousness more than 5 minutes. Number two, if there is any fat. If there's any? Number three, amnesia. If this person does not recall what happened. Number four, if there's 3 or more vomitings, episodes of? I'm talking about the children or adult? Children. Because adult is something else, is 1 or more than 1. Adult is more than 1. More than? Children 3 or more. So, if there's 3 or more episodes of vomiting, if there is drowsiness, if there is bruises more than 5 centimeters, so if his head is bruised and the bruises is more than 5 centimeters, and if there is any leakage of fluid from his nose or his ears, yeah, his nose or his ears, clear fluid, indication CT scan. So, guys, again, CT scan indication: loss of consciousness more than 5 minutes, fit, amnesia if he cannot recall, vomiting 3 or more. That's for children, but adult more than 1. Abnormal drowsiness if he's not himself drowsy. If there's a bruise bigger than 5 centimeters, and if there is what? Leakage fluid from his ears or nose, and even if there's skull fracture, depressed skull fracture. Anyway, these are the indications of this scan. So, guys, the case I will give you, guys, please listen carefully to me, because there is a reason. From the case, if you understand it, life will be easy. The case I will give you now, a mother whose child had a fall. So what is the presenting complaint? Fall. So easy. In the fall, guys, always during and before and after, exactly like that. Fit. Before, during, after. I will explore the fall in details: before, during, after. During the fall, did he injure his head? What happened during the fall? Okay. What was the type of the floor? If he fell on wood, it's not like the same as carpet, it's not like the same as glass. So type of floor. How high? Okay. Did he fall from? This is all exploring during. Before the fall, what happened just before the fall? Did he lose consciousness then fall? You understand me? Because maybe he will lose consciousness then fall. Okay. After the fall, what did you do? What did you see? Because maybe she saw blood, maybe she saw clear fluid. So what did you see after the fall? Was he having any effect? Was he vomiting? Clear, guys. So now exploring the fall is exactly the same way as exploring the fit. During, before, after. Okay. Doctor, what's his name? Dr. Mahmoud. In this case, when you are exploring the fall, if you find any indication for management is CT. If no indication for CT, no CT reassurance, go home. Under observation and then go home. This is the purpose of the case. So, P1 is fall. I explored the following details: before, during, after. Then, I will go into DDs. DDs, but quick, or in details, quick. Any head injury, any discharge from nose or eyes, yeah? Any vomiting, quick. Then when I'm asking questions, I'm actually asking the questions for indication of
CT.
I give you the indication of CT. What are the indications of this scan? Loss of consciousness, ask here. Did he lose consciousness? Second indication, fit. Did he have any fit? Third indication, drowsy. Was he feeling drowsy? Fourth indication, vomiting. Fifth indication, bruises. Any bruises? Yes. If she said yes, ask her how big. Sixth indication is clear fluid from everything is negative. So this case is about, in my differential, is actually asking about indication for
CT.
Because when he had a fall, he had head injury. This is the case. What happened? He had a fall and he injured his head, doctor. Explore about the fall. Before, during, after. Very important. Is he recalling what happened? So, and after explore the fall, before, during, after, ask the indication for CT scan. Now, she told you, she gives you, there's two scenarios. If she gives you bruises 10 centimeter, what would you do? CT scan. If she gives you bruises 12 centimeters, CT. If she gives you vomiting one time, CT? No, but observe, under observation now. If she gives you vomiting 4 times, CT. So in this case, in the exam, either she will give you one of the indication of CT scan for you to say CT, or she doesn't give you one of the indication for you not to do CT, reassurance syndrome. But make sure in this case, ask about NAI. It's not gonna be NAI case because they cannot bring two cases together. They cannot bring NAI case and head injury case. Difficult. But ask about
NAI.
Is it important?
Yes.
Guys, head injury, fall.
Yes.
So how's things at home? Who does he live with? Yeah, with me and my partner. How's things? Do you get on well? Yes, doctor. That's it.
Okay.
Clear? So NAI is a must in this case. The next case is NAI case. So the next case is let me give you the scenario. So 3 years old. 3 years old Adam was brought by his mom. Because he's having a swelling around his left arm. X-ray was done and showed spiral fracture. This is the question again. What is the question? 3 years old Adam was brought by his mom because he had a swelling around his arm, left arm. X-ray was done and showed. So basically at the door they are telling you NAR, non-accidental injury, because spiral means twist. NAR, that's it. So listen carefully. How can I help you? Doctor, my son has swelling around his arm. That's the complaint, yes or no? Yes. Explore. When did this happen? How did this happen? Why do I ask when did this happen? Because if the mother brought him late, if this happened 5 days ago and she brought him today, delayed presentation means NAI, non-accidental injury, means abuse. So when did it happen? How did it happen? Which arm? When it happened, were you there? She will say, no. Who was there? My partner. Did you ask him how it happened? Yes, doctor. What did he tell you? Clear. Yes. So that's exploring that. Presenting. Guys, are you lost? After exploring it, my differentials were in the structure. NAI. The question said it's NAI. The question said it's a spiral fracture. So I will bring NAI question, one or all? I will bring the NAI questions here. I'm sorry, I'd like to ask some questions that may sound intrusive, but it's a part of my consultation to make sure that everything is okay. Then start asking environment. Because I said to you NAI, if you go to the first slide, NAI means environment. Who does Adam live with? Doctor, me and my partner and my sister. Who's looking after him mainly? Doctor, all of us. Then start with her. And then her boyfriend, and then the sister. The 3 of them. Okay, how do you get along, you and Adam? So I'm using the mother now, yeah? Talking about the mother now. How do you get along? Doctor, we get along really well. The second question. What do you do for a living? The third question, are you managing financial? The fourth question, alcohol. The fifth question, drugs. I call them stressors. You know what I mean? Stressors mean this. Anybody who's not managing financially, who's taking drugs, they get stressed, they beat the child up, maybe. Then, was it planned pregnancy? To see if he was a wanted child or not? Is he your only child, or do you have other children? Because maybe if he's getting abused, other children are getting abused. Then coming back to that, what is the second part? The second person here? Boyfriend. Your boyfriend, how is he? How is the relationship between him and your son? Is he the biological father? I want to ask, is he the father or not? Okay, if she said no, he is not. Where is the biological father? Does he look after the child? How is the relationship between him and the biological father? Same. I can't suspect everyone. Then ask about occupation. What does he do for a living? Any stressors? Is he managing the financial? Does he take alcohol? Does he take drugs? Coming to your sister and ask the same questions.
Okay.
Clear, guys? Yeah. That's basically establishing what's happening. Because your job, next job is social services. So I will ask NAI early, and then quickly I will go through the diet and the dehydration. Wow, why diet and dehydration as well? Because maybe they're not feeding him. Maybe he's feeling dehydrated. So he will need to be managed right away with fluid. Maybe he's not eating well, you know? Now, what is the management? What is the management? Guys, the management, listen carefully. Admit, number 2. Senior, number 3. In the investigations. All the blood or not? All the blood. In the question, they said they've done X-ray. Do you need to do X-ray again? No. So we need full skeletal survey. So X-ray on the whole body and CT scan on the why? Shaking heavy syndrome, or maybe when they beating him, when they pushing him, when head injury. So full skeletal survey. CT scan on the head. Fundoscope to see if there's any injuries in the head, any injuries in the back of the eye. These are at any children getting abused. Any child getting abused, I do the same. X-ray on the affected arm. But it's done. I need to mention full skeletal, CT, and even I can take photography. Why? For medical legal issues. So we can take a full photos of the injury and any bruises in the body. Clear? Yeah. This is investigation. Step 4 is management, symptomatic treatment. Step 4 is the child is in pain. Give him painkillers. The child is having fracture. So stabilize and refer to orthopedic. And step 5 is a specialist. Who's the specialist here? Social services. If she said to you, doctor, will you take my son from me? Say to her, social services doesn't mean that I will take your son. Basically, we are caring about your son as much as you do care about your son. Social services, their main concern is keeping the child under his family supervision. However, our priority is keeping him under your supervision and under your care, but we need to make sure that he is safe.
How do I say the photos part?
No, you can say, and we'll take some photos for the injuries. Yeah.
Okay.
ممكن تجمع من الصياد؟
Yeah.
دكتور خالد حسنية. Okay, next case. Let's have something. Let's have some donuts. That's right. Okay?
Okay.
Not much to go. Not much left.
Okay, that's good.
That's all calculated in the time of the video. Perfect. So, next case is ear infection. Ear otitis media. It should talk from us 4 minutes because we discussed it where with the febrile convulsion. Yeah? You are an FY2 doctor in the pediatric department. Alex, 9-month-old, brought by his mom. He is pulling his ear and is having fever. Simple. Be careful because this case can come and there is no examination needed, no otoscopy, and can come where there is examination needed. What do you mean, Dr. Mo? I can open the cubicle and see otoscopy there, or I can open the cubicle and there is no otoscopy, just a history taking, which means I will take longer history. Okay? If I open the cubicle and there is otoscopy there, that will be discussed in examination stations. Short history, tiny history, examine, manage. But if there is no otoscopy there, if there is no mannequin there, so it's a history taking station.
Okay.
How can I help you? Present a complaint, she will tell you, my son is tugging his ear, or my son is having a pain in his ear. What to do? Explore. Tell me more about it. Which ear? What about the other ear? When did he start pulling his ear? Okay?
Okay.
Any discharge from his ear? Apart from this, anything else? Yes, doctor is having fever. When did it happen? Did you give him any indication for it? Yes, I gave him Calpol. Did it help? Did it improve? And that's it. That's the 2 complaints. Tugging his ear and having fever. Apart from this, anything else? Should say no. Then, what are you coming now into? DDs. Present the complaint finished? DDs. Head to toe or development or in the eye?
Head to toe.
Head to toe. Head injury? Yes. Under the head is meninges. Important? Fever. Fever, you must exclude meningitis. So, any rash anywhere in his body, shy from light, he's 3 years old, you can say next step, or you can say if he's younger, 9 months, 8 months, when you carry him, is he in pain? And then go to the next one, which is the ear is finished. So any discharge from his eye or his nose, then go to the mouth. Ask about the feeding and ask about vomiting. Then any swelling in the neck, infectious mononucleosis, any chest, any bleeding problem, no. Any vomiting, any diarrhea, no. Constipation, no. Any pain while passing urine, is he crying when he's passing wee? No. That's it. So what is the case? Otitis media. Now, when I come to differential finished B2 squeak, has he had this before? Past history of medical condition, or does he have any medical condition that he goes to the GP for? No. Bird quickly. 1 question each. Bird. Triple D. I will ask about the diet, about his feeding. I will ask about dehydration. Is it important, dehydration? Fever. Dehydration. Important. Is he crying without tears? Is he wetting his nappies as often as he used to? Then go after that to MAF. Allergy is very important because in this case they may have the child with penicillin allergy. Be careful because the child might have penicillin allergy. Anyway, after that, verbalize examination of the and observation. After that provisional diagnosis, I'm suspecting that he's having ear infection, and management. Is it self-limited or not? She said to you, doctor, ear infection since yesterday, fever and ear in the pain since yesterday. It's usually what? Viral, goes on its own. However, we will manage the symptoms. So what is the management here? The management here is simply supportive treatment, painkiller, calpol, paracetamol, plenty of fluids, light dressing, and safety net, very important. Any case of otitis media, safety net for meningitis. Because complication is please, safety net, any case of otitis media
For meningitis.
meningitis. So say to her,
Okay.
if he's not himself, lethargic, unwell, sleepy, rash, bring him right away.
Okay.
Or if he's not improving, bring him right away. Okay? Scenario,
No antibiotics.
no admission. Common scenario is delayed walking. Delayed walking. Delayed walking. Okay. Before I start this case, I would like you to know delayed walking in the structure. Where? Development. Development. So development is where delayed walking comes.
Yeah.
So, would I ask the questions for development or not?
Yes.
You remember them?
Yeah.
The gross motor and the fine. I will recap them quickly. The gross motor, I said, gross motor, 3, 6 to 9, 1 to 3. 3 months, supporting the neck. 6 to 9, sitting, buttocks. 6 sitting with support, 9 sitting without support. 1 to 3 is 1 is start walking. 2 years old is
Stairs.
up and down the stairs. 3 years old is
Tricycle.
tricycle. And then the fine touch, I said the fine is bottom, big bottom opening at 2. How many is? 2. 3 is
Grasping.
grasp. Okay, and then I said 4 and 5 is the other fine development. Then I said to you that will be in details or not? In details. What about head to toe? Fever or discharge? No, not really. Is he fit and well? And that's it. Okay? So I'm just giving you that what we're gonna do here in the structure. So we're gonna bring the development here. So what is the presenting complaint will be? Delayed walking. Then you will explore. After you explore the delayed walking, what will come here? Concern. Concern. What's your main worry about it? Then after concern, you will come to DDs. In your DDs, which questions?
Development question.
Development. After asking development, quickly go through the rest.
Okay.
But now, delayed walking. Delayed walking. What could be the causes? Which means, if I'm having a child who's delayed walking, what are the things that I would think of? First of all, if the child is, because that's the exam question, if the child is 14 months, can you say he's delayed walking? No. Guys, delayed walking and delayed talking, we only suspect after 18 months. Again, delayed walking and delayed talking, we only suspect after
18 months.
So I will give you a scenario. If a child came, his mom brought him, he's 14-month-old, and she said he's delayed walking or delayed talking. When I take history, since when, and I explored, and then when I went into causes, I found that everything is normal. The child doesn't have anything. Can I reassure her or not?
Yes.
Yes, I will reassure her, because delayed walking and delayed talking, if the child is totally fit and well, we can say that he's delayed walking or talking after
18 months.
So we can wait from 14 to 18 months, and after that we can say, we can run investigation, we can see that he's delayed walking or talking. Do you understand me?
Yes.
Clear?
Yeah.
So if the child is 14-month-old, delayed walking or talking, but everything else is normal, everything, can I wait and assure?
Yes.
Yes. That's one key point you need to know. The second key point that you need to know, so I said to you, the first key point, After exploring the problem, delayed walking or talking, I will bring what? Development question. The second key point I said to you, if everything is normal,
Yes.
and he's 14, delayed walking or talking, so then reassure. The third point is the causes of delayed walking could be malnutrition, so could be feeding problem, could be diet problem, yes or no? So his bones are not strong. So diet is important or not? Feeding is important or not? Number two, could be another condition called Duchenne muscular atrophy, remember? So is it genetic? So do I need to ask about family history? Do I need to ask about other sibling and how are they?
Yes.
So that's one point. So the first point, malnutrition. So you need to ask about
Malnutrition.
diet. The second cause is genetic, Duchenne muscular atrophy. So ask about family history. The third cause is head injury, can lead to delayed walking. So ask about any head injuries, any past head injuries. Guys, am I making any sense?
Yes.
So what are the three things I will targeting on my history?
Families.
Family history,
Like,
because of genetic.
Yeah.
Diet, malnutrition, head injury. Okay?
also full term or preterm.
100% birth, I said it must be asked. Because full term and preterm, yes. So let's read the question. 18 months old, 14 months old, 14 months old, yeah, 14 months old. Adam was brought by his mom because he is delayed walking. So this is the station will go. How can I help you? Doctor, my son is delayed walking, I'm very worried. Why are you worried? Doctor, he's delayed walking, he's late walking. He's 14 months old. Explore late walking. When you say late walking, do you mean that he's never walked? Or do you mean that he started walking but now he's not improving? When did you notice? Apart from this, did you notice anything else? That's exploring the condition. After exploring, what's your main worry? What's your main concern? That's a concern. After that, I will go to my differential. Differential in brackets. Which questions? Development. So is it okay if I ask you some questions about his development? Yes. When did he start? Crawling. Walking and crawling.
Yeah.
When did he start crawling? When did he support?
His neck.
When did he sitting with support? When was he standing? Because standing is important. That's late walking. At what age was he standing? Did he take any steps? So I'm asking the questions: neck, buttocks, leg. The one that I told you.
Okay.
Yeah. Any other delay in his development? I'm asking about other problems. No, doctor. Now, I finished my questions for development. Everything else is negative. Go to birth. B. Birth. How is his birth? Full term or premature? Immunization. Red book. Development already asked.
Yeah.
Then diet. Important.
Yes.
Yes. What do you give him? Dehydration or not? And you can ask about
Head injury.
head injury. Everything is negative. So general physical examination for the child as an examination, and then what is your management? How would you manage?
Yeah, sure.
Reassurance. So you will say to her, well, from what you've told me, you've mentioned that this and that, and I noticed that there's no other developmental delay. Your main concern is him delayed late walking. However, we only consider children late walking when it's beyond
18 months.
18 months. So we'll wait and see. But safety net. If you notice anything else, if you notice any problems, if you notice any other developmental problem, if he's not himself, bring him right away. And in medical condition, you can ask about what? Medical condition, you can ask about what? Bone disease, as a direct question.
Green stick fracture?
Hmm?
Green stick fracture?
Plenty of things in bone problems.
Okay.
You need to ask about any history of any bone problems in the family. Yeah? Bone disease. Okay. Now, sorry, I showed the mother. Okay, you can do some investigations. Yeah, you can. You can do routine blood to check if there's any malnutrition. You can do creatinine phosphate kinase again. So you can do some blood investigations. Yeah. But the main thing is the assurance. Yeah. Do you need to review the child? Yes. Do you need to have a follow up? Yes. So follow up, but don't worry, you need to give a time. Yeah. So follow up. Okay. And red flags, we know if he's floppy, not himself. If he's developing any other condition, yeah, bring him right away. Okay, next case is autism. Next case is autism. Okay, you are an FY2 doctor. A mother of Jason who's 3 years old brought him because she has a concern. Guys, autism, is it development or is it medicine? Development. So what is the presenting complaint of autism? Write down, presenting complaint of autism. Questions must be asked in autism. Number 1, which basically specific autism. Questions equal autism. What are the complaints that she will have? So I will think of autism. Number 1, withdrawn from people around him. In brackets, doesn't show affection. Number 2, if he's withdrawn from people, he's attached to object. So attached to object. Number 3, repetitive behavior. What is the meaning of repetitive behavior? He build blocks and destroy. Build again, destroy. Build again, you know, they've got a certain behavior that they keep repeating. So repetitive behavior. Plus or minus delayed talking. What do you mean, Dr. Mo? What do you mean? I mean that these 3 symptoms are must. Withdrawn from people, attached to object, and repetitive behavior. Can it come with delayed talking? Yes. Can it come without delayed talking? Yes. So plus or minus.
Okay.
Okay? And guys, whenever you have somebody who's delayed talking, what question you need to ask? Tongue tie. You know the tongue tie?
Yeah.
When the tongue is stick to the floor of the mouth. So always ask, when he was born, was he having any problem feeding? Because these kids, can they drink milk?
No.
Can you move? Can you drink something without your tongue moving? Can you? If my tongue is not moving, can I drink something?
No. Okay.
So a question easy to exclude tongue tie. Because tongue tie, can it lead to delayed talking? Yes. And basically, they open it and start talking. So be careful that whenever there is a word delayed talking in a case, say, has he been diagnosed with a condition called tongue tie? Did he have any problem having his milk when he was young? Clear? So it's a simple, superficial, easy. It shows that you know things, just like Anyway, so autism. What is the presentation? 3 symptoms. Child delayed. Child withdrawn from people, attached to objects. So it's both opposites. Withdrawn from people, as repetitive,
Behavior.
plus or minus. This is the presenting complaint.
Okay.
That's how she bring him with one of these things. Okay? Okay. When she brings him with one thing, listen carefully. So the question is, a mother brought her son Jason, 3 years old, because she's concerned. How can I help you? What's your main concern? So doctor, he is not showing me affection. He is withdrawn from people. What to do? How to start? Explore. What is the presenting complaint, guys? Withdrawn from?
People.
Or doesn't show me?
Affection.
Explore. It doesn't show me affection. That's the complaint. When did it happen? How did it start? Was he showing you affection before and then he stopped? Or that's from the start? Okay? Apart from this, any other symptoms? No, doctor. Like what, doctor? Then you ask here the rest. Is he attached to
Objects.
objects? Does he have any repetitive behavior? How is his
Talking.
talking? I ask the rest. You mentioned to me that he's not showing you affection. Exactly as if, guys, if you understand the station, if you understand it, you don't need to memorize.
Yeah.
You told me he doesn't show you
Affection.
exactly as if low mood. As if low mood. Have you changed home recently? Has he changed nursery recently? Does he have any problem in his nursery? How does he get along with his friends and teacher? Maybe it's something with his mom. Maybe he's shown affection to others, teachers, you know. Did you speak to the teacher? Is he, if he's going to nursery, by the way, yeah? Does he show them the same feeling? Does he show them affection? If you thought of what I'm saying, it's a logic questions. Anyway, she will give you the presentation of the 4 things, which is autism. After asking all these questions, this is the presentation. Then I will start having my differential. All this was presented complete. Now I'll start, what is my differential? Development or what?
Development.
Ask. Is it okay if I ask you some questions about his development? Yes, doctor. When did he support? When he was able to stand, when he's able to walk. Development. Everything will be negative.
Okay.
Then after development, medical condition, bear the triple D quickly. So you are fixed only with the symptoms for autism. Guys, are you lost?
Yeah.
Okay?
Okay.
So then provisional diagnosis. Can you diagnose autism confirmation? Confirmed? No. So I'm suspecting a case or a condition called autism. I'm suspecting, yeah. It's unfortunate, but in a as if you are breaking bad news, yeah. In a, you know. Unfortunately, if it is such a case, it is long life condition. Okay. So doctor, so what's gonna happen? Say to her, it is a condition that, what is autism? It is a condition that affects people and it affects the way they understand and they interact with the world around them. That's autism. So that's autism. It affects how people interact and how they deal with people around. This is autism. So it is a condition that affects how people interact and how people deal with people around them. That's it. Please don't think of it as a problem that needs to be fixed. Please accept the way Adam or Jason is. That's it. So that's the provisional diagnosis. Please don't think of it as a problem. Please accept the way Adam or Jason is. And it is a condition that affects how people deal with the people around them. She will ask, doctor, is he having this because of MMR? It's a question. May I ask why you think so? Always ask her, why you think so? Because I heard the MMR causes autism. Does it cause autism? No, MMR doesn't cause autism. It's just that children show signs and symptoms of autism around the same time when MMR was given, but it doesn't cause autism. Okay? So this child will need to be referred, okay, to autism clinic, okay, that's like specialist, but say to her, he will need at least 6 months assessment. He will need what? 6 months assessment, and I will need to refer him to autism team, and the referral will take 3 months to be referred. So again, how long will he be assessed for? 6 months. Where will we refer him to? Autism clinic. Okay, and the referral will take up to 3 months, and they will assess him, and they will go to the office. Okay.
Is there any investigation?
No. Okay. Night terrors. Night terrors. Guys, what is night terrors? Before I give you the case, what is night terrors?
Child having nightmares.
Nightmares. So is night terrors the same as nightmares? Okay, night terrors is basically child, it affected children between 3 to 12 years old.
Okay.
That's the age affected, 3 to 12 years old. Okay? It is basically a sort of sleeping disorder, as if they are having a sleeping problem. I'm just giving you the explanation and how, because you should understand the case. So night terror is something that affected children between 3 and 12 years old. Basically, they wake up in the middle of the night, shouting, screaming, angry, jumping out of bed. That's it. Okay. Is night terrors nightmares? No. What is the difference? Night terrors, they don't remember what happened. They don't.
Remember what happened.
And when you wake them up, they don't recognize you at the time. They don't recognize the family member? Yes. Nightmares, they remember what happened. And when you wake them up, they know you are the father.
Okay.
So again, this case is night terror case. Before I go into what is the case, I will tell you night terror is a case that affected children between 3 and 12. This case, simply, when a child is having night terrors, he wakes up in the middle of the night, he screams, he shouts, jump out of bed. If you wake him up, he even shouts more and gets more angry, and he does not recognize you, and he does not remember what happened. Nightmares, he remembers what happened, and he recognizes you. Okay? So, in this case, listen carefully. What is my history? My history in one word. Environment. What do you mean environment? Simply, they found that one of the main risk factors, one of the main causes of this, is the children having stress in their life. So now, in this case, you will be trying to look for stress. That's it. Stressors. Khalid is looking at, it's just saying, pediatrics is so easy. It's not really. Stressors means that I will be asking about the home environment. Who do they live with at home? Any problems at home? How do they get along with everyone at home? I'll be asking about nursery or the school if they go to. How's things in the school? How do they get along with people in the school? Do they have any problem in the school? Have they changed school recently? Any missing? Any pets that they had and died, passed away? Maybe he had a dog that passed away. Maybe she had a cat that passed away, causing stress. Have they moved homes recently? So I will be looking for any stress in their life. That's it. This is the history. So the history equal environment and anything that can cause stress. What about the management? The management simply. As I said to you, when you wake them up, what happened?
Don't recognize you.
And they get more. So don't wake them up. I'm just giving it to you guys in a village simple way so you understand it before I start it. So don't wake them up because that will increase their anxiety. However, diary, record the timing when they wake up every time in the middle of the night, and before this time try to wake them up so you break the cycle. For example, they keep having these night terrors between 2 and 3 after midnight. Wake them up before to break that cycle. That's it. Show them affection, show them love, bedtime stories. Do not show them anything scary before they go to bed. Do not show them any scary movies. Do not show them some. So that's it. That's the management. And this is the case. So, you are referred to doctor in the pediatric department, 5 years old. That makes the station easy. Rather than reading, that makes the scenario easy. 5 years old, Alicia, her mom is concerned about her because she wakes up in the middle of the night screaming. That's the case. So, how can I help you? My daughter is Wake her up in the middle of the night, what?
Screaming.
What to do? Explore. Presenting complaint. When did it happen? How did it happen? When did you notice? Have you tried to speak to her? To the daughter? Ask the presenting complaint. After exploring the presenting complaint, when did it happen? How did it happen? What do you do when this happens? Very important. What do you do when this happens? Very important. During this episode, have you noticed anything different? Like, does she have any effect? Does her eyes, what? Roll up? Does she pass any wee or poo? You understand me?
Yeah.
These are all questions during that. You try to find out what happened during this episode. What happened? When did it happen? How did it happen? How often does it happen? What do you do when it happens? And when it happened, did you notice anything different? Does she have a fit? Does she have her eye roll up? Does she pass urine? Does she pass stool? You know?
Okay.
Then, after you ask about the presenting complaint in details, as I said, ask her about her main concern, and then go to DDs. What are the DDs? In brackets, what?
Environment.
Environment. So the DDs in brackets, environment. Again, the DDs in brackets, environment. What to ask about environment in this case?
Stressors.
Environment. So who does she live with? Everything is okay at home? School or nursery? How does she get along with school or nursery? Any problem in the school or nursery? Environment. Has she changed home recently? Has she moved recently from home, from school? Pets, dogs, cats that died recently? Something that causes stress. Any death in the family? All environment stress, and then quickly build the triple D. Okay, so she will tell you, doctor, why is this happening? You will tell her usually it happens because of stress. When a child is going through stress in his life. Doctor, is it nightmare? Is it nightmares?
No.
No, it's not nightmare. Night terrors and nightmares are different. Night terror and nightmares are different. What is the difference, doctor? I told you that. In night terror, they cannot remember. But nightmare, they do recall, they do remember. Management, what is the management? I told you. What is the management? Number one, notice the time when the episode happened. And what to do? Wake her up to break the cycle. Number two, when this happens, if this happens, wake her up or not?
No, don't
Stay calm. Don't approach her. Leave her until she is calm. Because if you do, wake her up, it will increase. Three, communicate with her. Try to discuss if there is any stress in her life. Maybe something bothering her. Then, before bed, no scary films, no scary movies, so go to sleep hygiene. And empty bladder before she goes to bed. Okay, next station is chlamydia eye infection. You are an FY2 doctor in the pediatric department. 10 days old. 10, how old? 10 days. Pat had red sticky eyes for the last 3 days. Swab was taken and shows chlamydia. Okay, chlamydia. Talk to his chloramphenicol was given. Talk to his mom, address her concern. Now, let's establish something. Is this case new diagnosed? So it's a case of you trying to diagnose, or is it diagnosed already? Diagnosed already. Okay, what do you mean, Dr. Mo? If the case is not diagnosed, I take history to reach. But if the case is diagnosed, I only take history to reach the cause, the risk factor. What do you mean, Dr. Mo? The case said to you swab is taken and it's a chlamydia. And he's 10 days old. What is the cause in this case? Maybe the mother had chlamydia, so when he was passing through the birth canal, he had it. So, sexual history of the mother. The cause is the mother. So basically in this case, you're not gonna focus much on differentials. You're just gonna ask about the eye, the discharge, from which eye, and what's happening, the color of the discharge, the nature of the discharge, then the cause, which is STI. Then the cause, which is STI. So sexual history of the mother. So the cause, which is STI. So it's basically a case of not history to reach chlamydia I, but it's a history to reach the cause. And then you will give the child the antibiotic for his eye, and you will give the mother antibiotic, and you advise her of safe sex, and that's it. Okay? So the case is, you are F1 doctor in pediatric department, 10 days old bat, had red sticky eye for 3 days, swab was taken, showed chlamydia. So diagnosed or not?
Yes.
Genetic history?
No.
No. Then, so when you start the case, so this case is about history of the baby's eye, quick. Okay? History of the baby's eye, quick. And the history of the mother to do with
Sexual history.
STI. That's it. So how can I? Is that how can I help you, station, or is that I can see from my note that the child had swab taken from his eyes and shows chlamydia?
I have it in my notes.
Yes, I can see from my note that the child, or your son, or Adam, or Thompson, or Pat had a discharge of his eye and it shows chlamydia. Yes, doctor. Explore. So, what was the color of the track, timing of the discharge, relation, amount, color, track. And after that, quick hit to is it medicine or is it counseling? Counseling, but diagnosed. So you can just ask any fever, any rash, anything else apart from. That's it. No doctor. No, nothing. Then you can go to the mother, sexual history. I'd like to ask you some questions that may sound intrusive. Ask sexual history, sexual activity, partner, safe sex, lower tummy pain, discharge. Why would I ask the mother about sexual history?
Because chlamydia was caused from her.
Because it's the cause. She is the cause. So I'm not only managing the child, but her as well. Provisional diagnosis. What? So, because the case is diagnosed, I always tell people, and I've done it in day one in this course, I've done it in day one, I said if the case is diagnosed, my history or my station is 3 parts. Part 1 is asking about the complaint, risk factor, complication. What do you mean by that? Because it's diagnosed. This is the structure for diagnosed cases like this.
Okay.
You don't take disease, you don't take differential. You just say, I can see from my note this, what brought you for this risk factor. Why risk factor, doctor? Because you want to know the cause. The second part is explaining the result for which she came. She came for swab result, explaining. The third part is management. So in this case, the first part is history. Okay? I. Cause is mother, sexual history. The second part is explaining the result. We have a swab positive for chlamydia. And this bacteria may be transferred to the baby during the birth, from the birth canal through you. The third part is management. So the provisional diagnosis, we have done a swab of the eye and it shows some sort of bacteria called the chlamydia, which I'm afraid it may have transferred from you to him during birth, so we should treat you as well. Management. Senior, azithromycin eye drops for who? For the child. The mother gum clinic. She will be referred to gum clinic. She will have STI screening. She will be on antibiotic for chlamydia. She will be advised for safe sex, and she will be asked to bring the partner. That's it. Are you lost? Seriously? Yeah. So this is the case simply. So be careful. At any time you have a case that is diagnosed, don't take history to ask for differential. Always say, I can see from my note that you brought Adam or Thompson or whatever for swab. Yes, doctor. Why did you bring him? Doctor, because he had discharge. Which eye, what the other eye, type, blue color, discharge. Right away, because you know it's a chlamydia from the question. Ask about sexual history as a cause, and then go for the second part, which is explaining that result, then manage.
Okay.
If we work on chloramphenicol eye drops, we will change it to
At this moment, yeah. Next case is primary enuresis, bedwetting. Next case is primary enuresis, bedwetting. Yeah. Alicia is a mother of 4-year-old child. David brought him because of bedwetting. Guys, just let me give you an advice. Whenever there is a mother who is bringing her child because she's concerned that he's wetting the bed, please always ask, was he dry before wetting the bed or not? Always.
Okay.
What do you mean, Dr. Mo? Was he always like this, or was he dry and then he started wetting the bed? So you want to know, is it a new thing or is it primary from the start? Clear? It's a key question.
Yeah.
If a mother brought her child saying he's wetting the bed, you want to know, was he normal? Then he started wetting, or was he like this since birth, from the start? Okay? So, Alicia, she's the mother of 4-year-old David. She brought him because of bedwetting. So what is the presenting complaint? Guys, what is the presenting complaint? Bedwetting. Explore. When did it happen? How did it happen? And is it every day or only at some days? Is it occasionally or? Yeah, he could be bedwetting once a week, and you could be bedwetting every day. So, and is it only night or also in the day? So, key question, guys, please. Is it only in the night time or day and night?
Okay.
Has he been dry before and then he started wetting, or he's like this all the way around? How often? Is it every day or only some days? Clear?
Yeah.
Okay, because he's wetting the bed, so it could be medical, it could be psychological. Always again think of psychology of the child. So I'm gonna ask in this case about any psychological problem. What do you mean psychological problem? Stress. So in this case, don't forget stress as well. Anyway, would you like to ask head to toe? Yes, because it's a medicine problem. It is a medical problem.
maybe UTI.
Maybe UTI, because UTI can lead to this. So always ask head to toe quickly.
Okay.
Any fever, rash, from light, vomiting, any discharge from that, ear or nose, vomiting, diet, chest, abdomen, pain while passing urine, changing the color or the smell of urine, so differential DDs. And in P2, which I've asked the question already, I said, has he had this before? So which is basically, was he dry then became wet, or was he always wet? Yeah?
Okay.
Then birth. In birth, what is important? Birth, premature and full term. Is it important? Yes, 100%. Premature and full term is very important. Is very important. Is very important. Yeah, to ask.
Okay.
Was it premature or
Full term.
full term? And from the whole of the birth, the last D. What is the last D? NAI. It's not NAI, but in brackets, environment. Because it can cause, stress can cause him to do better even in adult. By the way, adult they can have incontinence because of stress. Okay? So I will ask in D, NAI, I will ask about how's things at home, who does he live with, the child, who's looking after him, does he get on well, you understand? Like environment, change school, change nursery, lost anything that's dear for him, like relative, pet, very important, okay?
Okay.
So again, how can I help you? Doctor, my son is bedwetting. When? How did it happen? Was he dry when he started wetting bed, or it's always like this? Day, night, both, special days, every day. After that, main concern, after that, DDs. DDs, quick head to toe because it could be UTI. P2, birth triple D. In birth,
Okay.
very important full term and premature. And development, how is his development? Okay. Then go to the NAI question. It's not NAI but environment.
Environment. Okay.
Now what is the examination? Verbalize. observation and general physical, and then go to the diagnosis. He's 4 years old, never been wet before, you understand? Sorry, never been dry before.
Right.
So primary aneurysm, primary. It's almost like this. So reassurance, say to her, stomach children will grow out of it, and later on, you know, they will start not wetting the bed. So they will start to grow out of it. Reassurance case. Management, in brackets, one word.
Yeah, sure.
Management is lifestyle.
Lifestyle.
Management is what?
Lifestyle.
Lifestyle. What do you mean lifestyle?
Stressors.
If there's any stressors, make sure no stressors. Before bed, discourage you to drink fluid. During the day, encourage to drink fluid and go to the bathroom. Think about it. Think about it. He's wetting the bed, yeah? So before bed, what you need to do?
Don't drink fluid.
Discourage to.
Eat or drink.
And before bed, you want to take him to?
Bathroom.
Bathroom. During the day, drink fluid and empty bladder as well. Environment stressors.
Remove.
So the management is number one, encourage. Encourage what? Plenty of fluid during the day. Encourage what? Go to the, so encourage number one. Encourage what? Plenty of fluid. Encourage what? Go to toilet during the day. Yeah? Encourage what? Going to toilet before he goes to bed. Discourage. Number two is discourage. Discourage what? Fluid before bed. Discourage fizzy drinks. Reward. Reward him if they are following your advice. So encourage number one. Discourage number two. Reward if he's following the advice. And the environment, as I told you, make sure that there is no stressor, there is no bullying at the school, there is no stress. Make sure the environment is okay. Number five is follow up. Follow up if it continues after the age of 5, after following all these measures. So follow up if it continues after the age
5 years.
of 5 years old and we following all these measures, then we're gonna go further assessment and referral to specialist or in neurologist clinic. You can even say to her, consider alarm to go to the loo.
Okay.
Any problem.
No.
So encourage, discourage, reward, environment. If it continues after 5 years, you will need further assessment and referral to a neurologist clinic. Okay.
Son was less than 5 years old?
Constipation, sorry?
Less than 5 years?
Yes, less than 5 years. Constipation. It's a very easy and a very good case that you do nothing on it. Constipation. Constipation in a child. So, 2 years old was brought by his mom because he's constipated. Because he's what?
Constipated.
I want you to remember two things. Potty training and the stressors.
Okay.
What do you mean, Dr. Mo? Potty training, maybe if she's new in training him in the potty, so he's scared to do it in the potty. That's why he's constipated. Remember the second word, environment. If he's stressed, any stressors, he will be constipated. So 2 words to remember in this case, constipation in child. What are the 2 words?
Potty training and
Potty training and stressors. So the question, and when the child is constipated, we do nothing but lifestyle. Plenty of fluids, fiber, you know. So you are an F1 doctor in the GP clinic. A mother of 2-year-old visited the clinic because her son is having constipation. Her son is constipated. Okay. So how can I help you? My son is. What would you like to ask in constipation? Since when? How did it start? When you say constipation, do you mean he's not passing his stool at all? Or do you mean that he's trained to pass his stool? And for how long has it been going on? And was he normal? Then he started being constipated? Is it on and off? Or since he started having this constipation, he's struggling with it? So that's that presenting complaint. You remember yesterday, whenever you have one of the abdominal symptoms, this is if you go to gastroenterology. I said whenever you have one symptom, ask about the rest. Abdo pain, constipation, diarrhea, vomiting, and fever. These 5 symptoms, they come together. Abdo pain, abdominal pain, constipation, diarrhea, fever, and vomiting. Whenever you have one, ask about the rest. So in this case, I will ask the GIT symptoms. Apart from constipation, any tummy pain? Is he bringing his legs toward his tummy? Any diarrhea? Any vomiting? Is he passing wind? I want to know, is it open or not? Any fever?
Okay.
And then after I ask the GIT symptoms, guys, because I said yesterday, whenever you have one, just to ask the rest. Quick differential. What do you mean quick hit to do? Constipation, is it medicine or development medicine? So quick hit to do. As we know, because it's a medicine case.
Okay.
Quick hit to do. Everything will be negative. Everything will be negative. Just the constipation.
Okay.
Be careful because in the third D, triple D, what is the last D? In AI, which is environment. So ask about the environment because the first 2 words I said before I started constipation, I said potty training and stresses. So ask about the environment, school, change nursery, any stress going on in his life, and ask about potty training because potty training can be a kind of stressor. So if he's new in potty training, so have you started potty training him? Yes, doctor. So that could be one of the factors because they get scared. Okay.
Okay.
Now management, I said nothing but lifestyle. Management, I said what?
Lifestyle.
Nothing but, what do you mean lifestyle? So, simply, by the way, if she gives you any of the environment factor, don't forget to mention it. What if she said, well, he moved the school, he moved the nursery, we sold his pet, is that a factor?
Yes.
So, be careful, yeah? Because I said to you, potty training and stressor. What if she said, yeah, I started potty training him? Can I tell her to stop it for now?
No.
Yes. If she started potty training him, and that's why he's psychologically not happy, can she stop it for now and try it later?
Okay.
Yes. So management, I said simply it is what? Lifestyle. What do you mean? Dietary advice. High fiber diet. Fruit, veg, plenty of fluid. Make sure that your son or your baby is active, mobile, mobility. From yesterday I said in gastroenterology, mobility. So, number 1, dietary advice. Number 2, potty training. If you are potty training him, what to do? Make sure he is resting his feet on the floor, and make sure he's assured, not worried, not upset, not scared. So, what is the first advice?
His legs are on the floor.
Diet. No, what's the first advice in the management? Diet.
Right.
Plenty of fruit and veg and fiber and fluid. Second advice to do it, potty training. Leg rested, comfortable, Prince. Comfortable, leg rested, reassured, not worried. What is the third advice? Stay calm and reassured. That's it. So, do not stress him out into pooing in the potty training. Do not stress him out. Do not show anger or frustration that he's not doing it. So the third is her, herself. Don't show him anger. Don't show him, any frustration. Then get the child into a routine or a habit of going to the potty training. And laxative are not recommended. Laxative are not recommended. Okay? Laxative often recommended only if the children eating solid food. But in this kind of case, is he eating solid? He's young. So when do we recommend laxative?
When he's eating solid food.
When eating, so I cannot give laxative to a child who's drinking milk. You understand? So when they are eating solid food, then we can recommend laxative treatment. Okay?
Okay.
Yes. Okay. And there is a note here, once constipation, if the child is eating solid food, if he's eating and he's constipated, so can I give him laxative? Yes, I said laxative not given only if the children not eating solid. Doctor, how do I know that he's eating solid or not? No, diet is important. Diet will be asked in the structure. Is there a relationship between that and the constipation?
Sure.
So if he's not eating solid, can I give laxative?
No.
No. But if he's eating solid, I will prescribe laxative. And be careful, because when you prescribe laxative and the child start passing stool, you cannot stop it right away. Yes. So once the constipation is dealt with, the GP will advise to continue laxative for a while to make sure that the poo is soft before stopping it. Yeah. Okay, guys, I'd like to give you the last station, neonatal jaundice. Okay, neonatal jaundice. I would like, before I talk about neonatal jaundice, I'd like to give you a key point, because this key point will make you diagnose and will make you reach and manage any case of neonatal jaundice. Okay, and the cause of neonatal jaundice. Okay. Neonatal jaundice, jaundice that affects neonate. Is it common? It is common. Is it harmless? It is harmless, unless. So again, neonatal jaundice, common and harmless. No harm. Normal for children to have neonatal jaundice. Normal for children to have jaundice. So I can have a mother who's bringing her child with jaundice and reassure, unless. Number one. So what are the points or the key points where I'm worried? Number one, if it's in the first 24 hours. So jaundice, if it's in the first 24 hours, it is dangerous. So what is the first principle here to tell you that when you have a mother who's coming with neonate who's had jaundice, what is the first question?
When did it start, or how old is he?
When did it start? And how old? How many days is he? Because if it happened within the 24 hours of birth, serious. What is the second condition that if it happens, it is serious? If the bilirubin, if he's got jaundice and the bilirubin is increasing by more than 5 mg per deciliter per day. So today is 90, for example, tomorrow's 100, after tomorrow's 110, so it's increasing by more than 5, serious. Number 3, if the total bilirubin is more than 17, serious. So if it's 10, 12, 13, it's fine, 14. If it's more than 17 total bilirubin, serious. If it is increasing by what? More than 5, serious. If it's appeared within the 24 hours, first 24 hours, serious. The last one, if it is got infection with it, if the child is feverish, if the child is having any illness, if the child is having any infection anywhere in his body with the jaundice, it is serious. Guys, are you following?
Yeah.
So what are the 4 points that I'm looking for to exclude serious jaundice? Number 1, first 24 hours. So I need to ask about timing. Number 2, if it's increasing by 5, more than 5, so I need to measure it and follow it up. By the way, every phrase will give you something you need to do on the station.
Okay.
So if it's increasing by more than 5, how would I know? I follow it up and measure it. 3, total bilirubin more than, so needs to be measured. Last, if the child is feverish, so in that case I need to take history of head to toe. Do you agree?
Yeah.
Because if he's got any source of infection, it's dangerous. Otherwise, reassure. Now, what is the normal jaundice where I can reassure? It's a jaundice that doesn't have any of these 4.
Okay.
Number 1. and it is a jaundice that developed 2 to 3 days after birth. Oh, yeah, it makes sense, Dr. Mo, because you said if it's in the first 24 hours, it is serious. So if it appears 2 to 3 days after birth, it's fine. So the physiological jaundice, number 1, common. Number 2, harmless. Number 3, when does it happen? First 24 hours? No. 2 to 3 days after birth. And they last till 2 weeks.
Okay.
Till 2 weeks. Okay? Now, premature babies, it can take up to 3 weeks. Premature babies can take up to
3 weeks.
3 weeks. And babies who are breastfed can even take longer. But do you mean Dr. Mo take longer? So if he's breastfed and he's got jaundice, no, follow him up, safety net, exclude no infection. So, the first principle, neonatal jaundice, harmful or harmless? It's harmless, unless 4 things. First 24 hour, increase by 5, more than 5. If it's total more than 17, if it's fever. Don't miss these things. Okay, physiological jaundice, the normal one, 2-3 days after birth till 2 weeks. Can it be 3? Premature. Can it be longer? Breastfeeding. Okay? Pathological jaundice, be careful because you always, I said to you, pathological jaundice, what is the last point in the 4-point pathological jaundice?
Infection, fever.
If it's temperature infection. So always ask about head to toe, and always ask, is he poor feeding, high pitched sound, dark urine, dry mouth, is he lethargic, all these signs of infection. Yeah. Okay. Now, do you know the history or not? Yeah. Be careful because the pathological jaundice, that we spoke about, how do we know the pathological? How do we know it's a pathological? I told you. How do we know pathological? More than 5, increase every day, more than 17 total. If the child is, what are the causes of pathological jaundice? So when I'm taking history, to know what are the causes that leads to this kind of jaundice, the bad one. Logically, what is the first cause? Infection. I told you, infection. So number 1 cause, infection. So very important to ask questions about infection, fever, in this case. What is the second cause of jaundice, the bad one, the ugly, horrible one? Blood group incompatibility. Yeah, blood group. Do you know what I mean? Blood group incompatibility can lead to jaundice. So do I need to ask about the child blood group?
Yes.
And the mother's and the father group? Guys, I'm gathering the history with you. After this, you should understand. You should understand. So, infection to exclude in the history. Blood group to exclude in the history. What's his blood group? What's the mother blood group? Hypothyroidism? Oh, very common cause of jaundice. So, by asking about any concerns that she had, any family condition, any thyroid problem in the family, okay, any constipation, because hypothyroidism in the children and neonate can lead to constipation as well. By the way, congenital hypothyroidism, hypoconstipation, hyperdiarrhea, yeah, and biliary atresia, very common, congenital, dark urine and pale stool. So guys, I should be finished from the jaundice, and I explained it to you in a very nice, simple, we broke it down. Leave this. How can I help you? Doctor, my son is jaundice. Doctor, my son is yellow what? Discoloration. So what is the presenting complaint? Yellow discoloration or jaundice. What to do? Explore. But very, very, very important question. When you explore the jaundice, what? Timing. Why timing? Guys, left is about asking relevant. Strong, relevant question. You can ask me 100 irrelevant. Timing. Why timing? Because the bad jaundice is the one that comes in the first 24 hours. What about the good one? The good one is the one that appears 2 to 3 days after. So first I'll ask about timing. I ask about time. I explore the jaundice, come to the main concern, and come to the differential. Differential. What is my first differential here? Infection. Again, it's one of the 4 things. One is timing, one is infection. Why, Dr. Mo? Because it causes kernicterus, very dangerous jaundice. So I ask about infection, any fever, any rash anywhere in his body, any discharge, look quick, any discharge anywhere, you know? No. After asking about the timing, and in differential, ask about the head and toe to execute infection. What else can I ask about? Blood group and cross matching. And I will ask her about her blood group, the child blood group, the father blood group, as a second cause of bad jaundice. Third, thyroid. When he was born, were you told that he's got any medical condition or anything? Did you have any concern? Any medical condition that runs in the family, like thyroid, like gland in front of your neck, from your side or the partner side? So blood group is asked. Thyroid is asked. Infection is asked.
Timing.
And then timing is asked. Covered. Other than this, if it's jaundice that started 2 to 3 days after, fit and well, healthy, and it's up to 2 weeks, breastfeeding can take longer. Premature can be 3 weeks, reassured.
Okay.
Other than this, you need to manage. Other than this, you need to manage because it's pathological jaundice. You need to monitor the bilirubin because total of more than 17, dangerous. Or increase of more than 5. Did you understand anything?
Yeah.
Understand? No. Memorize. So, how to manage? So now, I don't need to give you certain script. I can make from this 5-6 cases. People say, Dr. Mo, in these cases, people get 0 because they just scripted to 1 case. But if they go like this, look for infection, look for thyroid problem, look for blood group problem, look for congenital anomaly like biliary atresia, dark stool and pale urine, okay? Sorry, dark urine, pale stool. Look for the child fit and well, do the investigation, check the level and the increase in level. I mean, you've got plenty of scenarios under one topic. Because I cannot change it. Does that make sense? I can bring in the case of reassurance, I can bring in the case of management. So, management, if it is physiological jaundice, if I'm taking history, nothing, fit and well, healthy, 2 to 3 weeks started, 2 to 3 days started after birth, he's fine. Reassurance. But when you reassure, no need for medical treatment. Make sure you safety net. Why? He may be sick or it may be prolonged physiological jaundice. Maybe he will feel unwell, he will be start being so safety net. Monitor at home and safety net. And if it continues more than how long, come back 2 weeks. Because usually it should go on its own after 2 weeks and 3 weeks in premature, yeah, come back. What if he's premature? What if he's premature? Again, it's fine, reassure. But here investigations are needed because in premature children, they can have any thyroid problem, any blood problem. So you will need some investigation, thyroid function test, blood test. Okay? But again, if everything is negative, reassure. But when you reassure, do you need to safety net?
Yes.
Monitor at home? Yes. The third, I'm discussing different management of different scenarios. Okay. The third scenario, if it is the bad one. The what? What is the bad one? The one with infection, the one that's more than 17, the one that's increased more than 5, the one, you know? What to do? Phototherapy. Photo, which is the light. Yeah? The baby will be in his cot, under ultraviolet lamp, naked, with only one thing covered, the eyes. So the child will be under special light. Under?
Special light.
In his cot. In his cot. Under? Body is
Naked.
naked. Eye is
Covered.
covered. What about his feeding? Should we? Yes, we'll change his nappies. We'll keep feeding him because we don't want him to be dehydrated from the light. And we will monitor his temperature, and we will monitor his dehydration and his bilirubin level every 4 to 6 hours. So think about it. Jaundice, 2 to 3 days after, child is fit and well. What to do?
Yes.
Reassure,
Safety.
monitor, safety net, come back if it's prolonged more than 2 weeks. Premature child, jaundice, 3 days after birth, reassure. Investigation here, because he's premature. Investigation, thyroid function, bloods, everything is normal, reassure. Monitor at home, safety net, if there's anything, come back. If the child has an infection, fever, one of the bad ones, what to do? Photo, thoroughly. Child will be naked, only the eye is covered, but the child will be monitored every 4 to 6 hours. Monitor what? Bilirubin, yes, to see the level. Monitor what? Temperature, monitor dehydration, which will be under light. Yeah, and you need this child needs to be treated for the infection, because what is the cause? So manage for the infection. But if it is continuous, the bilirubin is increasing after all of this, blood transfusion. Blood transfusion, blood transfusion, blood transfusion. Okay. So connectors is a condition where the bilirubin level will be more than 150. That's above the treatment level. The treatment level is above 150. Now, almost safety net for infection, fever, almost. Safety net for infection, fever, everything. So, guys, quick recap: 15 years old, noticed by his mom or by the midwife to be yellow or to have tinge, yellow discoloration of the skin. P1 is yellow discoloration. Explore. First and most important question when you explore, timing. Then sight. Sight, where is the discoloration?
Yes.
Yeah? Then concern, main concern. Then differential. And differential head to toe to exclude infection. What are my differential? The first thing is kernicterus. What? Which is infection causing this. By that, I'm recapping what I said. By that, I will ask, is he active, playful, shallow from light, fever, which is the head to toe, infection. Then, the second is obstructive jaundice.
Yes.
Biliary atresia,
Yes.
dark urine pill,
It's
stool, don't forget. And then you will go to P2, medical conditions, birth, triple D, and in birth, you need to ask if it's mature, triple D, dehydration. Why? Because he's gonna be under, and because the infection can lead to dehydration, multiple. And examination head to toe, investigation, blood, full blood count, all bloods, liver function, thyroid function, bilirubin level, clear?
Yes.
Management, as I told you, depending on the cause, safety netting is for kernicterus. If it's normal, always safety net for kernicterus, which is if he's drowsy, not himself, feverish, any signs of infection. All the time, yeah? Another case is, and the final case is, boom, 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 okay? Is tantrum, okay? A final case is tantrum. Tantrum. Guys, what is tantrum? Listen carefully because it's very easy case, so I'm gonna finish in like 20 seconds. What is tantrum? You need to understand it so you don't spend so much effort to memorizing. Tantrum is a spoiled kid. What do you mean spoiled kid? In Arabic, عالم الدلع. So tantrum is the kid who is spoiled. His family are spoiling him. For everything, he cries, he throws things, he pushes things. Tantrum. That's it. This is tantrum. You are an F1 doctor in the general practice. A mother wants to talk to you regarding a 3 years old child. What are the features? What is the presenting complaint of tantrum? Look at the complaint, and now you know it is the tantrum case. He's always the child throwing things, pushing things, crying for things, hitting and biting. Hitting, biting, throwing things, kicking things, that's the complaint. That's the complaint, okay? So, it's a way of showing frustration. If they need something, they behave like this. Okay. So basically in the history, nothing but doctor, he throw things, he's pushing me, he's biting. Explore. When, how did that happen? Since when have you noticed this? Was he okay and then he started developing this? And simply because he's a child that's spoiled, maybe he needs something. So ask, when does he do this? Always ask about environment, stressors, environment and maybe that's frustration, stressors. So it's a case of spoiled kid. You will do nothing about it. So in management, you will basically say to her, understand and accept that this is the child anger. Try to find why he's doing it. Talk to him. Ask him why he's doing it. Find the distraction. Find the distraction means, distract him straight away. When you see that he is starting, distract him. Look at the cat, look at the dog, look at that, distract him. Okay? Wait for it to stop. Don't interfere. If he's losing his temper, don't interfere. Wait for it to stop. Like what? Like nightmares and night terrors. When we said night terror, don't wake him up. Wait for it to stop. Okay? If he is doing this because he wants something, this is all advice. Who am I advising?
The mother.
If he because of something and you said to him, no, don't change your mind. Stick to your mind. Just stick to what you decided. Okay? And tantrum, be prepared that tantrum always happens when you are doing shopping. When you are out in the shops, that's when they do it.
Okay.
So that's it. So basically, what is tantrum?
Silent
Spoiled kid. Spoiled kid. His complaint will be spoiled. Cries, push things, explore everything. Ask about the environment, maybe frustration around him, maybe things bothering him, relationship with people around him. Always environment, okay? What do you do with it? How do you ask him? How do you deal with it? You should not show him any anger back. Then come back to management, nothing but when he's doing it, leave him to it, talk to him, see what is the reason, try to, when he's having this anger, don't be frustrated, leave him as it is. If you do something, if you decide something, don't change your mind. Why? Because if she changes her mind after doing this, he will carry on. That's it.
Okay.
Guys, I hope you had fun.
Yeah.
It was how long? 2 hours and 40 minutes. Okay, so we've done all the stations. Thank you very much.